Hello, good afternoon. Good evening.
Yeah, good evening.
Yeah.
Okay, today I thought we'll talk about kidney failure or renal failure. That is, Sally, can you tell us what do you understand if somebody has renal failure?
Yes, Dr. Saliu. Okay, inability of the kidney,
Okay.
kidneys to remove excess
Ah,
fluid and mineral elements from
okay.
the
So
body.
how much of the kidney has to be damaged before the patient becomes symptomatic? Because you know that we do kidney transplantation. So for kidney transplant, we take one kidney. So the recipient, the donor has only one kidney. He does not go into renal failure. So how much of the kidney has to be destroyed before any symptoms occur?
Above 80%.
No,
Above
50%
80%.
means okay, you're safe, but ideally you need to have almost 80-90% of the kidney to be damaged before they become symptomatic. Okay. How do you calculate kidney damage or kidney function? If you look at the slide, what is GFR?
I can't see the slide.
Okay.
I can't see the slide.
Okay. What about others? Are you able to see the slides?
I can.
Last time also you were not able to see the slide. Okay, anyway. What about that Elijah? Are you able to see the slide?
I see the slide.
Yes or no? Okay.
I can see the slide.
When you consider renal failure, usually about more than 80% of the kidney has to be damaged before the patient becomes symptomatic. And the kidney, the main function is to filter the blood and remove the unwanted substances from the blood. And this starts at the glomerulus of the kidney. And the kidney function is calculated as glomerular filtration rate. So when the rate becomes less, then there is kidney failure. So what are the causes for kidney failure? It can start even before the kidney, which is called pre-renal, or it can be after the kidney because of obstruction, which is called post-renal, or it can be in the kidney, which is called intrinsic renal dysfunction. So the problem can be either before the kidney or in the kidney or after the kidney. So can you name one cause for each? So we'll start with the post-renal or obstructive. So what can cause obstruction to the kidney? Nutritional. I think you're the only one who can answer. No. So what can cause obstruction to the kidney so that there is renal failure? Yeah.
Reflux.
Okay. So after the kidney, the urine comes to the ureters, then the bladder, and then the urethra. Okay. So one of the most common causes of post-renal obstruction or kidney damage is bilateral ureteric stones. In fact, earlier when we were traveling all over the place, at least one patient will see every month who has ureteric stones, which block both the ureters. The block may not be total or complete, but even then significant damage can occur. If there is a complete block, within a month, kidney will be totally destroyed. And the treatment is fairly simple. Sometimes you may not even see, at least in this X-ray that you see here, you can see the stones on both the ureter. Sometimes these stones may not be even seen. So just putting in a stent or DJ stent can relieve them of the obstruction and restore normal function. We had several examples of patients who come with a creatinine of 20, 28, and so on. Some people with totally anuria or without passing urine. Then when we're able to put in the stent, then within days it becomes normal. So this is one thing which needs immediate treatment. Pre-renal causes are actually more difficult to treat. This is because the less blood comes to the kidney. This can be due to septicemia, shock, or severe injury, and so on. So these actually need a proper medical treatment. And then there are some medicines which are toxic to the kidney, or there are some chemicals which are toxic. These cause renal kidney damage. So the damage can occur either before the kidney, in the kidney, or after the kidney. And what is acute renal failure? So how do they present? So they present with symptoms of what is called acetamia. Then they have oliguria or anuria or mild impairment. So what is acetamia? What happens in acetamia? What do you understand by acetamia? Okay. So this is because of usually the kidney filters the substances which are toxic or which are not necessary for the body, which need to be removed from the blood. And when the kidney is not able to do this function, then these products accumulate in blood. So this can present to start with this just fatigue or lack of energy. Then there can be loss of appetite, nausea and vomiting, general muscle weakness. And then it starts affecting the heart when the pulse can either become rapid or slow or irregular. And finally, it can even lead to loss of consciousness or coma. So this is, and this time when you measure the urea in the blood, it'll be very, very high. So these are generally called as symptoms of acetamia or renal failure. So this is how when this happens usually with acute renal failure. While in the chronic renal failure, because the renal failure occurs slowly, these symptoms are not generally present. Yeah. So how do they cause the problem? Why does this renal failure occur? So the primary problem is that there is renal vasoconstriction. So with vasoconstriction supplied to the kidney, it becomes less. Normally about 25% of the cardiac output goes to the kidney, which is very, very high for a small organ. And that is necessary because the kidney is the one which filters and needs to remove all the toxic substances from the blood. When this vasoconstriction is there, two things happen. One is that the kidney cells themselves can have ischemia and die because of the loss of blood supply or vasoconstriction. And it also increases the fluid overload in the body. And if left for a long time, it can actually cause irreversible damage. So you need to detect it before the kidney damage occurs. So how do you do it? Dr. Sally, have you understood what is happening, what we've been describing?
I do.
Okay. So how will you find out? Because it is important to find out whether damage is reversible or irreversible. So you calculate what is called, you calculate the urine sodium and plasma creatinine, and plasma sodium and urine creatinine. So this ratio needs to be less than 1 if it is normal. So anytime this ratio goes to more than 1, it means already some damage has started occurring. This is called sodium clearance. So you need to calculate the sodium in the urine, creatinine in the urine, same thing, plasma and creatinine and plasma sodium. These are simple lab tests which can be done. And then once there is also what is called a renal autoregulation in the kidney, which affects the blood flow to the kidney and the rate of filtration and the way the kidney functions. So this autoregulation is also lost if there is constant vasoconstriction and ischemia to the kidney. Right. And then if this continues for a while, then there is impairment of sodium and water reabsorption. So where does the concentration happen? See, normally we said that almost 25% of the blood supply goes to the kidney. So if you look at the shape of the kidney, it has a loop like this. So it gets filtered in the glomerulus, it goes down. And in the ascending loop, most of it is reabsorbed and then goes back into the circulation. Well, and almost most of the filtered blood will get reabsorbed and go back into circulation through the renal vein. But then if there is any tubular dysfunction, that this process of reabsorption also is affected. And one of the mechanisms by which it gets affected is that there is a release of nitric oxide, which is due to ischemia. Is that clear, Dr. Selyu?
It's clear.
So what are the causes of acute renal failure? So what will lead to this renal vasoconstrictions? One of the most important cause that we'll encounter often is septicemia. And urosepsis or sepsis because of urinary tract infection can be quite serious, and they very often cause septicemia. Then severe blood loss, severe dehydration, and trauma, especially if there is a crush injuries. Road traffic accidents where quite a bit of muscle damage is there. They also cause proximal vasoconstriction because the body, what it tries to do is to, first priority for the body is to send the blood to the brain. And it slowly starts shutting down the blood supply to the other areas to maintain the blood circulation to the brain. And the kidney being one of the organs with a lot of blood circulating, it gets affected first. So one of them, and hypovolemia, less volume of blood also can contribute to this severe vasoconstriction. So one of the often forgotten method loss which occurs with peritonitis burns. Same thing with the muscle trauma. Here there is systemic vasodilatation and there's not enough blood circulation going into the kidney. So all these are causes of pre-renal renal dysfunction. And then the importance of this is that once there is kidney damage, it can also lead to lung damage, it can lead to heart damage or liver damage, and slowly it goes into multi-system organ failure, from which many of the patients won't come out. So when do you suspect renal failure? So if there is increase in serum creatinine, which is above 50% of the normal value. So you need to know what is the normal value. So what is the normal value of creatinine? approximately? Does it have a range or is it a fixed value?
Has a range.
Yeah, it does have a range. So what does the range depend on? Is primarily on the size of the patient, the muscle mass of the patient, and so on. So if we see the range, it gives here as normal is 0.5 to 1 in normal. So, but then even 1.1, 1.2, 1.3 may be normal for a heavy built person. So that is why we need to suspect that there is 50% more than normal. If the previous value is 1 gram, if it goes to 1.5, then it is subnormal. Or if you're treating the patient daily and you note that there is an increase of 0.3 milligrams per day. So then again, you need to suspect there is renal failure. Another important indicator is the urine output. See, normally we produce about 1 ml per kg per hour. And if it stays less than half ml per kg per hour, especially if it continues for more than 6 hours, then you need to suspect that there is something wrong in the kidney. And again, the renal failure could be oliguric, which means that the non-oliguric, which means the output is more than 400 ml per day, or oliguric if it is less, or anuric if there is no urine output at all. Okay. Then how do you manage it? So it again depends on what is causing the obstruction. Anything, Dr. Selyu?
Yes, I'm sorry.
Yeah, if you're not asking, talking, please mute because there are a lot of external noise which other people can't. Yeah. Okay. So the pre-renal failure is there. Then the important thing is to increase the urine output to the kidney. So how we do it is to increase the fluid. So you give IV fluids, you correct the electrolyte imbalances, and then if there is anything particular toxin which is causing the renal failure, you stop that. And then also one of the recent finding is that if you give a short-acting vasodilator and solutions like mannitol, this increases the renal blood flow. And of course, there are many newer studies which show that you can give things like stem cells, epithelial cells, and specific nitric oxide inhibitors, which will improve the renal failure if there is a pre-renal renal failure. But then, as I said, these are conditions which probably need expert medical management for managing it. The only thing that it is possible for rural surgeons to do is to increase, if there is dehydration, then give enough fluids. If there is electrolyte imbalance, you correct those. And then you can give drugs like dopamine and mannitol, which will increase the blood supply to the kidney. Right. Why is it important? Because if there is, especially with renal causes, the mortality is very high with the renal failure. In fact, there is, 20% mortality if there is slight decrease or less than 25% decrease in GFR. And if there is, it lasts longer, and if there is injury to the kidney, it can be up to 36%. And if the kidney is not functioning and stopped functioning for a while, the mortality can go up to 46%, almost half the patients can die. Anything? Okay. So, summarizing, what are the possibilities of treating acute renal failure in rural areas? So, the first thing that you need to do is give adequate fluids to make sure that there is enough volume. If the blood volume is not maintained, you can give medicines like mannitol, which tends to keep the blood volume and prevent the losses. And dopamine, which again is a vasodilator, which helps in renal vasodilatation. The reason why you need to do that is that once there is renal failure, then all these toxins start accumulating. And then it will cause failure of the other organs, starting with the lungs, liver, and heart, and so on. So the primary source is or problem is the renal failure, which occurs with the acute renal failure. And that needs to be corrected. But if it's not possible to do all this with the medicines, then the next option is peritoneal dialysis. Peritoneal dialysis also is not a very difficult thing to do, because if you have those fluids which are used for dialysis, you can either have insert a long-term catheter like this, or if you don't have anything, just any silastic tube also, silastic Foley's catheter with multiple holes also should suffice. You put that and leave the dialysate or peritoneal fluid for a while inside the abdomen, 2-3 hours, and then take it out. And if the post-renal, of course, you need to learn how to do DJ stenting, and that will help. Sometimes these stones may not be very easily seen. So if there is a total anuria, or if you suspect the cause is a post-renal, it's safer to do a DJ stenting anyway. What about chronic renal failure? When does it become chronic? So far, we are talking about acute renal failure. So, Dr. Selly, when do you call renal failure as chronic?
Chronic renal failure has lasted up to that.
Yeah,
3
when
months.
so it
Renal
3
failure
months
has
is lasting for 3 months, and this, of course, is has other features like it has additional protein excretion, and then, of course, progressively decreasing GFR. So what are the tests which will tell you whether, these are the various stages of chronic renal failure. Stage 1, when the GFR is almost normal. Stage 2, between 60 to 89. Stage 3, 30 to 59. And stage 4 and stage 5. And this picture shows how much kidney has to be damaged. This is on both sides. One kidney is okay to survive. And chronic renal failure also, you need to be aware that it's a common condition. Almost in some of the Western countries, 1.8 to 3.2% of the population has the disease. And in some countries, its rate is almost 1.5% every year. So the number of people with chronic renal failure keeps increasing every year. So what are the things which will tell you whether the renal failure is acute or chronic, from what you have learned so far, before you go to how to manage chronic? Because many of the acute renal failure, most of the time it is sort of reversible. And unless they're very, very sick at the beginning, with the severe multi-organ failure and so on, if they survive that period, then it is good. So what are the things which will tell you that, okay, we can comfortably manage this chronic renal failure in rural areas? So what are the tests that can tell us? What is, Dr. Selly, can you tell just one thing which will differentiate whether the kidney is chronic renal failure or acute? If I ask you for just one investigation, what would you do?
Duration is number 1. Duration.
Okay, duration. For duration, investigation test. Okay. What will be the size of the kidney?
Will are shrunken.
So if it is normal, then it's more likely to be acute. If it is already shrunken or massively dilated, then it's more likely to be chronic. Okay. And what about have you noticed the hemoglobin of the patients with the renal failure? Most of them have severe anemia. And there is a strong correlation between anemia and the severity. So if the renal function, the renal failure is more severe, the hemoglobin level is lower. So the reason is that kidney is what produces erythropoietin. Erythropoietin is a hormone which is necessary for. Yeah. Okay. Erythropoietin is a chemical which is necessary for production of the red blood cells. Now, of course, there are other factors because of iron, folate, vitamin B12 deficiency, then hyperparathyroidism, GI bleeding, inflammation, short RBC survival. All these contribute to the anemia. So the worse the anemia, the severe the damage and poor the prognosis. And another thing which occurs with the renal failure, especially in chronic renal failure, is that it affects bones quite a bit, because hypophosphatemia is one of the things which occurs with the renal failure. So this results in low calcium, which leads to secondary hyperparathyroidism. So it can cause diseases like osteodystrophy, osteitis fibrosa, osteomalacia, and osteodystrophy. Basically, what it means is that it affects bones, and the bones become brittle, they break easily, and calcium, which is necessary for a lot of functions, is low. So it is important. One of the important risk factors in the way the disease progresses. So it is important to find out what are the foods which are rich in phosphorus, and they need to restrict those. And if necessary, you need to do serum calcium levels and phosphate levels, and give phosphate binders, and vitamin D and calcium mimetics. So basically, you want the calcium level to come up to normal, for which vitamin D and calcium supplements are necessary. And we want the phosphate levels to become lower. So we restrict the phosphate in the diet, and also give substances which bind to the phosphate when it passes through the intestines. So whenever you're looking at the diet for renal failure, it's important to remember the phosphate levels. And most of the renal failure patients will ultimately die of cardiovascular problems. So any kidney problem can actually lead to high blood pressure. And the interesting thing in renal failure is that whether the systolic blood pressure is high or low, both indicate poor prognosis. And if they have diabetes with the renal failure, it again dramatically reduces the prognosis, because it causes quite severe damage because of inflammation and proteinuria and so on. So you need to have a very good control of diabetes. And then you should check for markers of inflammation. And if there is proteinuria, that needs to be taken care of. So one of the mainstay of treating patients with renal failure is to take care of the nutritional issues, because it affects proteins, water, salt, potassium, and phosphorus. And it can cause what is called uremic malnutrition. So this occurs because we don't give the specialized food for patients with renal failure. They may be taking food which is normal for others, but that itself can cause renal failure in these patients. And of course, if these patients have early dialysis, it improves the nutrition status and improves the outcome. So these are some of the things which they can consume quite comfortably. Any of the cereals like white rice, any wheat products, legumes, pulses, dal or chickpeas, Bengal gram, and those sort of things. And fruits like papaya, pineapple, peach, berries, apple, guava, and all these things can be consumed without any problem with the patients with renal failure. On the other hand, they should avoid the sodium-rich foods like processed foods, canned foods, foods that contain preservatives, and then avoid phosphorus-rich foods such as meat, chicken, legumes, pulses, and dairy products, and carbonated beverages also is an important contribution to phosphorus. Then again, high potassium foods needs to be avoided. These fruits like banana, mango, coconut water, avocado, and potatoes, and so on. Then avoiding sugary fruits and sweets is good for everyone. Okay. And you need to be careful about the amount of fluid that they take. Yeah. So what are the things which cause acute decline of patients in renal failure? So volume depletion is one of the things which can quite dramatically worsen the situation. So you need to be sure that the patients are not dehydrated. Then if there is a congestive heart failure, that can also decrease the blood supply to the kidney and make the progression faster. Then if there is any urinary obstruction, or if there is any hypertension. So all these things, and of course there are nephrotoxic drugs which needs to be avoided. So if a patient already has a renal failure, before they go into stage of dialysis or transplant, you need to make sure that these things don't occur and push them rapidly. So, but if you can't afford transplant or dialysis, so one of the ways of treating could be using infusion of loop diuretics. Then you can use calcium channel blockers or ACE inhibitors, and correct hyperkalemia and blood sugars. Okay. And diet, of course, needs to be very carefully monitored, especially low phosphate diet. And you can also give a calcium-based phosphate binder. So another thing to remember is that they also have metabolic acidosis because of renal failure. This has to be treated with sodium bicarbonate. So sodium bicarbonate is a cheap tablet which is easily available and can be treated, used. And of course, using recombinant erythropoietin, that helps them to have a high hemoglobin and a better nutritional status. But of course, if none of these work, then they ultimately will need either hemodialysis or peritoneal dialysis or renal transplant. So these are the indicators for dialysis. There's a mnemonic AEIOU. So if they go into acidosis, or there is more than 6.5, or metabolic acidosis, the pH less than 7.1, or if there is a rapid increase in blood urea, or if they have symptomatic uremia, then you have to be quick in offering them dialysis, which can either be hemodialysis or peritoneal dialysis. And generally, hemodialysis is preferred for older people. And if there is multi-organ failure and they need to be quick correction of the various problems. And if they also have associated respiratory distress or GI bleed. But the problem with hemodialysis is that you need to be near a place where this hemodialysis is possible. So in rural areas where hemodialysis is not possible, several studies have shown that peritoneal dialysis is almost as good as renal dialysis. This can be either ambulatory or continuous, or continuous cycling peritoneal dialysis. Ambulatory dialysis, you have a bag and you have these catheters, and patients can walk around and carry out the normal activities. While in continuous cycling peritoneal dialysis, you can do it in the night when the patient is sleeping. You need to sort of put up the fluid, let it go into the abdomen, wait for some time, and then remove the fluid. And one other problem is that the metabolic problems actually do persist even with the peritoneal dialysis, unlike hemodialysis. And ultimately, they'll end up having the need for transplant. But you need to realize that whether it's a transplant or peritoneal dialysis or hemodialysis, the costs are almost the same. Because even after transplant, you need to take immunosuppression, and any infection had to be very actively treated, and so on. So finally it boils down to the fact that how much they can afford and what sort of quality of life they're looking for. Okay, any questions? Dr. Selly, have you understood? Hello, now we can, I think I'll stop sharing. We'll unmute and...
We can start with peritoneal dialysis.
Pardon me?
Can we start with acute kidney injury?
Pardon me, I'm not able to hear what you're saying.
Dr. Ganaraj?
Yes?
When you do peritoneal dialysis, what dialysis do you use?
So there are several ready-made solutions. Baxter company produces them. So
Okay.
the Baxter company produces ready-made fluids. So they're available at 3-liter bottles. So you need to buy those commercially available ones, which are cheaper.
Does that make the cost prohibitive? Or?
See, in Indian rupees will cost about 12 to 15,000 rupees a month. It's about, say 500 means about $10 a month. No, 10. See, the costs are roughly the same, whether you use the peritoneal dialysis, the fluid, or what you pay for hemodialysis or the immunosuppression medication. Both work out to around the same per month. But the quality of life is better after transplant. But then you need to invest quite a bit of money for the transplant.
Do
Any
you
other
have
question?
data? Yeah. Do you have any data about survival on long-term dialysis versus transplant?
See, the transplant has the highest survival. In fact, even recently, one of the patients who had transplant in CMC Vellore is still alive, and he has gone into the Guinness Book of World Records for longest transplant survivor. But then, actually, I did one quality of life survey when I was training in Vellore. We talked to about 100 patients who had transplant. Most of them died within 3 to 5 years. And the family felt that, it could, they would have been better off they had not gone through transplant. Because it doesn't immediately, except for few patients where the take is good, the match is good, and they don't have any problems. Others, it's not the end of the story, because they do have to keep on going back to the hospital for various complications, and then getting the immunosuppression is difficult, and so on. So many of them, they are drained both emotionally and financially, especially if they don't have any other support for paying for them. So in fact, many of the journals refused to even publish the data because it was not a good data to publish, because it will affect the various transplant programs. And that is one of the reasons I was not interested in transplant at all. But on the other hand, we preferred peritoneal dialysis because you don't have to go to a city or urban center where patient has to shift from the rural area. Peritoneal dialysis is possible at their home. And many of them, after 1 or 2 weeks, they accept the fact that they have renal failure and their life is short. And once they accept that, then they have some time to take care of the thing they want to do. So this peritoneal dialysis gives them the option of doing whatever they want to do. And then they prepare for the eventuality. And one of the things we found was actually the initial cost also was high because of the specialized catheters which Baxter sells. They sell for, those days they were selling for about 12,000 rupees, so 15,000 rupees per CAPD catheter. But then when we made it custom made, it's just an ordinary silastic tube. So you could even custom make similar catheter for 600 or 700 rupees. So if you don't have these specialized catheters, you can always use ordinary silastic Foley's catheter. You cut multiple holes and put it and keep changing it. These will get eventually, whatever catheter you use can get blocked after 2 weeks or 3 weeks, and they need to be changed. But the important thing, of course, is to get the supply of the solutions, dialysis fluid.
I don't know where we can get it here.
You should be able to
It's
find.
a-
Any of the people who make IV fluid should be able to make the dialysis fluid, because the composition is slightly different, but it's similar to any of the IV fluids. So what we would recommend is that if any patient has chronic renal failure, you need to take care of the condition which will push them into further failure quickly. So you need to be careful about the diet, especially have eye on the phosphates, then the amount of fluids and urine output, then infections, hypertension, all these have to be quite actively, vigorously treated. Then once you do that, then you can buy time for that, so that the progression is slower. Any other questions? Okay, if nothing else is there, we'll close for the day.
Thank you, sir.
Okay, thank you. Good night.